Ooh. Shoot. Good afternoon, everyone.
Good afternoon, Lucy. Sharon here.
Hi, Lucy.
Okay,
Laura here. Are we meant to be on video or just on phone? I wasn't sure.
sorry, could you say that again?
Do you want us on video or just on audio?
We can be on video when we do the introduction, and then we switch off the videos as we proceed.
Okay.
Yes. So hi, Debbie.
Lucy,
Hi, Deborah.
Dawn is joining me, my colleague that works with me.
Yes, yes. Welcome.
Hi.
Welcome, John. Michael, is Michael on the call?
Yes, hello, I'm here, hello.
Okay, great. Great, thank you.
Going. There we go, hi.
Hi. Okay, so I think we now have everyone. We can begin. Okay. So good afternoon, everyone. Good morning, good evening. From the Center for Reproductive Rights, we are pleased to be engaging with you during this webinar on ensuring access to SRH information and services through telemedicine. We have 4 presenters with us who will be enlightening us some more on what all this entails. But before I get into introductions, I would like to just run us through a bit of some rules to ensure that the webinar runs successfully. So we are requesting that we keep our microphones muted and our videos off for those who are not presenting until we get to the point where we are discussing and or asking questions. If you have any question, please, if you have any comments, you can begin putting those in the chat box, and I'll be monitoring that and I'll raise that with the presenters. For now, I just want us to, because we have very limited time and the topic is quite interesting and broad, I'd like us to go into the conversation. As I said, we have 4 panelists. We have Michael Neville. Michael, maybe you wave to the presenters. Yes. Yeah, thank you. Thank you, Michael. Michael works at the British Pregnancy Advisory Service. He's the Director of Nursing. He's been in this position for 2 years now. He's passionate about provision of safe, effective, and empathetic abortion care, and strives to ensure that this is provided to all clients seen at the BPAS, that's the British Pregnancy Advisory Service. We have Dr. Deborah Constant.
Hello, everybody. Good afternoon, morning.
Yes.
Hi.
So Dr. Deborah is a senior researcher and director of the Women's Health Research Unit in the School of Public Health and Family Medicine at the University of Cape Town. And since 2008, her work has focused on improving access and quality of abortion care through improved regimen, self-management of eligibility and completion, and fast-tracking post-abortion care. So welcome to the webinar, Dr. Deborah, and we look forward to interacting with you. Then Patricia. Yes, Patricia is the medical director and responsible officer at the British Pregnancy Advisory Service, which is the leading abortion care provider in the UK. And then we have Professor Sharon Cameron. Hi. So Professor is a consultant gynecologist and lead for sexual health services at NHS Lothian. I hope I pronounced that properly. She's also the co-director, Clinical Effectiveness Unit at the Faculty of Sexual and Reproductive Healthcare in the UK, and the president of the International Federation of Professional Abortion and Contraception Associates. So thank you very much for joining us in this webinar. So I think we begin with the first question, which is, how does the legal framework in the context that you work in regulate telemedicine and self-managed abortions? And we can, so this is a question to all the panelists. We can begin with Patricia.
So the ability to actually deliver medications to people for use at home in the UK is relatively new. However, we have been able to undertake consultations remotely for some time. There's never been any restriction on that. And in fact, BPAS was providing consultations over the telephone to about 20% of our patient population before the pandemic. Early medical abortion is the choice of method for most pandemic happened. To give people misoprostol to take home from a clinic and use at home, but they had to come into the clinic to use mifepristone. With the onset of the nationwide lockdown in the UK on the 23rd of March, shortly thereafter, the government approved the ability for services to give both mifepristone and misoprostol to women to use at home, and that combined with the ability to undertake a pre-abortion assessment over the phone or via video call permitted us to develop what we called the pills by in which we send people a pack of not only the abortion medication, but also pain medication and a pregnancy test to use several weeks after the abortion so that they can then manage the remainder of their abortion without having to leave their homes. In England and Wales, the approval to provide people with mifepristone to use at home as well as misoprostol is linked to something called the Coronavirus Act, which covers a whole host of things, legislative changes that have been made as a result of the COVID pandemic. So that act has a sunset clause of 2 years, or when the COVID pandemic is deemed over. The situation with the approval for mifepristone use at home is different in Scotland. I'm sure Sharon can talk about that, but it isn't linked to the Coronavirus Act as I understand it. So they are not subject to the same sorts of constraints that we may be south of the border. And unfortunately, in Northern Ireland, it is still not possible for people to use mifepristone at home. So they remain in the position in that part of the medical abortion, while they might be able to have remotely, they would need to come into a clinic to use the mifepristone and then receive the misoprostol to use at home. So I'll pause there. I think that's just a sort of a brief overview of what we've been able to develop as a result of some of the governmental decisions that have been made during the COVID pandemic.
Thank you, Patricia. Dr. Deborah?
Hi, thank you. Thank you. Hello to everybody, participants, colleagues, and listeners in. So thanks for the opportunity to come on to this webinar. And interestingly, there's a webinar on exactly the same subject that took place starting an hour back and is just about to complete. So clearly we're all interested and possibly moving all in the same direction. That's hopeful. Right, so regarding legal frameworks, legislation and policies in South Africa that relate to providing medical abortions through telemedicine, probably the most important act, just to go through its provisions, the Choice on Termination Act, South Africa of 1996, is a liberal piece of legislation. It's been in place for a while and allows abortion without restriction in the first trimester, and permits minors to receive treatment without requiring parental consent, although they are requested to seek some form of counsel from an adult, but that's not required. Then the 2008 amendment to that legislation changed things such that trained and certified nurse practitioners could provide abortion, and although that it should be done in a designated facility, and that was the major change then. Since then, medical abortion using mifepristone and misoprostol was approved for the public sector. It was approved quite a way back as in terms of the mifepristone drug, but access in the public sector started in 2011 in the Western Cape with a series of guidelines that were published, and then has moved gradually and steadily throughout the country to the other provinces, so that medical abortion using mifi and miso combination is standard care for gestational age under 63 days in most places, but not all. However, this is an in-facility service. So that's really how the service is offered or has been offered to date. But in terms of telemedicine, we have had telemedicine in place in South Africa for various conditions and rendering various services for quite a while. The body that regulates that issued the ethical guidance is the Health Professionals Council for South Africa, which is the regulatory body for health professions. And they issued ethical guidelines in 2014. And the most significant legislation update is the statement that was issued by that body on the 3rd of April this year, in which they said, firstly, that telemedicine should be replaced by the term telehealth, which is sort of a more broad application. And I'm going to quote the change in legislation here, saying that telehealth should preferably be practiced in circumstances where there is an already established practitioner-patient relationship. Where such relationship does not exist, practitioners may still consult telehealth, providing that such consultations are done in the best clinical interest of patients. And that update certainly opened opportunities and is in place for the duration of the COVID pandemic, when it will be reviewed. But it obviously provides impetus. And so where we are at the moment is, I'd say, in brief, in terms of legal frameworks, getting there. But in terms of the public sector, there are an awful lot of barriers to be got through, not the least of which is regarding IT platforms and the kind of technological impediments that are in place. Having said that, certainly the NGO Maurice Stopes is offering a telemedicine service, and I understand that it's working well. They have a certain service delivery model, which I can explain later, but it's probably consistent, globally for Marie Stopes. And I do know that other NGOs are also, both IBIS and IPAS, are exploring this and hoping to take it forward with the kind of impetus that's gathering at the current time. So I think that's all for me for now on the legal framework.
Yes, thank you very much, Dr. Deborah. Sharon?
Hello.
Hello.
Hi. So, as Dr. Patricia Lohr has already mentioned, Scotland, where I work, we are part of the UK. And so we have to meet the legal requirements for the UK. So women need to be eligible for an abortion in the first place under the 1967 Abortion Act. Then we have very similar legislation, although it's slightly different. So we have legislation around women being able to self-administer misoprostol at home. And then more recently, as a result of COVID, the legislation that was introduced permitting women to self-administer mifepristone at home as well. And unlike England and Wales, we don't have the gestational limit of this being up to the end of the 9th week. And as part of the clinical guidance that supports the legislation in Scotland, telemedicine, self-managed medical abortion at home is conducted at the moment in the first trimester, so up until the end of the 11th week, 11 plus 6 days gestation. So that's where we differ very slightly. As Patricia has mentioned already, it doesn't have an expiry date, this new legislation, but it has been added that it's meant to pertain during the COVID pandemic, and that at some point in the future it may well be revoked. But we obviously hope that that will not be the case. Thank you.
Thank you very much. Then Michael, we can hear
Yes,
from you.
Thank you very much. So yeah, firstly, thank you very much for asking me to do this webinar today. The only thing that I want to add to what Patricia Lohr has said, I mean, we worked closely together, is around the fact that in the UK, the 1968 Act says that 2 doctors have to agree that a woman meets the grounds to have an abortion. The law is actually silent on how you could meet that, which is quite good for us to be able to provide a telemedicine service. And obviously, that was obviously because telemedicine wasn't around in 68. It does mean that we are able to get the 2 doctors agreement remotely, and we've been doing that for quite a while. So there is an allowance on a sort of team approach where the doctors can see the written information that nurses and midwives will have extracted during their consultation, so that the 2 doctors are able to make their assumption that somebody meets or agreement that somebody meets the Abortion Act in good faith with the information that was provided by nurses and midwives. So we've been doing that remotely with doctors for quite a while, even when patients have been seen face to face. Doctors have still been reviewing those case notes remotely and provide that agreement. So that's just the other thing that I wanted to add, because we do have that written into our law that 2 doctors have to agree that, and that's how we've got around that with telemedicine.
Thank you very much, Michael. So I'll just ask you if you could check your connection. There was a bit of, you are breaking a little bit, but we got what it is you are saying. Yes. So just confirm that your connection is okay, so that we can.
Yes, my connection is. Yeah, I've got good connection. I'm sorry about that.
Yes, we can hear you clearly now. So yes. So a question around the systems and mechanisms. So I suppose this would go to Michael and Dr. Patricia, just to speak about what, you know, the systems and mechanisms that your facilities have put in place to provide SRH services through telemedicine. And maybe you can speak about specific things like, you know, such as whether providers need special training to be able to provide services through telemedicine, and so on and so forth.
So I can speak a little bit about how we do it, and then perhaps Michael, you could pick up on what support we've provided to the nurses and midwives to deliver the service. So there's really two parts. One is doing the pre-abortion assessment remotely. And the other is providing people with the medications that they then use on their own at home. So the main thing that we needed to put into place at BPAS was transitioning from roughly 80% of our consultations being undertaken face-to-face in a clinic to the situation that we have now, where almost all of them are being provided over the telephone. So, so we've moved from, as I said before, 20% of consultations being remote to 97% of them being remote. And almost all of those are undertaken simply over the phone. We do use the addition of video calling for young people. So anybody under the age of 18, we do incorporate a video component to that consultation in order for us to undertake our safeguarding assessment with them, and also to obtain some visual confirmation that they are speaking privately, they're not being coerced. We do still have some people who need to have their consultation face-to-face for a variety of reasons. And some of that might be, for example, the inability to complete a safeguarding risk assessment confidently over the phone or with a video call. In order to support that remote consultation, we also do use a translation service for some people, and we can patch a translator in to do a three-way call. But sometimes that's not sufficient for the clinician to feel confident that they are having everything that they need to convey to the client be understood, and for the client to also express their needs. And so an in-person assessment may be required. Lastly, we do have some people who still require an ultrasound to determine either the gestational age of the pregnancy or to make sure that the pregnancy is not in an ectopic location. So although most people start their consultation over the telephone, some of them may finish it face-to-face. So the first thing that we needed to do was to shift the way that we were doing those consultations primarily to a remote model. And as I said, we had been doing some consultations remotely already, but we needed to train up a number of people to be able to transition almost everybody to a remote offer. And we needed to provide them with some infrastructure, right? So some people needed to have the telephone capability, for example, to undertake those calls. We also needed to develop the ability to record those consultations electronically and to have that information be uploaded into the medical record. So, and to date, we had been using just a paper-based system. So there were some documentary requirements that we needed to also put into place. The other remote aspect of the service is, as we've said, sending the medications to clients in the mail, or for some people, creating packs of medications that they could just come and pick up in the clinic, those people who didn't need an ultrasound. And I'll just focus on the mailing part of things, because I think that's what your main interest is in. But if you want to, we can also talk about how we prepare packs and so forth for pickup. But we have worked very closely with an online pharmacy partner to be able to deliver that service. And so we created the ability to send signed prescriptions to that pharmacy partner. And we worked with them to put together a little kit that they then send out to the patients with, as I mentioned before, mifepristone, misoprostol, pain medication, a pregnancy test to use in 3 weeks to see if the abortion has been successful. And we also will provide people with a 6-month supply of a progestogen-only contraceptive pill if they want that. And that pack also includes some bespoke client information materials about their treatment and how to use the tablets and what and how to check their pregnancy test in 3 weeks. We already did have, and we still provide access to, a 24-hour, 7-day-a-week telephone aftercare service. But we also developed more information on our website, including some videos so that people could access information if they needed advice or wanted to hear the advice or see the advice in a different sort of way about how they should manage their abortion on their own at home. So I'll pause there and allow Michael to pick up on some of the training needs.
Thank you, Patricia. I hope that you can hear me okay. Sorry if it wasn't so good earlier. So some of the things that we have needed to put in place in terms of training wise, just following on from what Patricia has said. I mean, I think that because of COVID, people were very welcoming of the opportunity to be able to work remotely, to be able to work from home. And so really it was embraced by our staff very well, and that was extremely helpful for us. But some of the things that we specifically needed to address with our nurses and midwives was things around sort of communication techniques. So there's a lot of information we're having to provide over the telephone. And it was about teaching nurses and midwives how to check understanding of that information. So getting clients to repeat information back, asking them, say, for example, what are they most concerned about, so that they could get some understanding of what they were saying. The other thing which was quite difficult was dealing with emotions over the phone. So we provided some training from staff who were used to doing telephone consultations about how to deal with staff that perhaps were emotional or getting upset. And also having the ability to recognise when you actually needed to hand that client over, when they might need some further counselling. So the ability to be able to stop the conversation and say, I really feel that you need to talk to somebody else before I go on with anything else. So I'm booking them in for some counselling. One of the things we discovered afterwards, that because there is so much information to share, I'm sorry, I've just had a message saying my connection is still not great. I'll come in and go out again a bit later. But one of the things that we found out was that people couldn't remember all of the information, particularly around what to do when their pack arrived, sort of 24 or 48 hours later. So we did make a video showing that pack, and actually there was a midwife opening the pack and showing the clients what was in the pack. So I know my connection's not great, so I'll leave it there and I'll log out and come back in again. I'm finished with that part of the conversation.
Thank you so much to both of you. So the same question Professor Sharon and Professor, sorry, yes, Professor Sharon and John, Dr. John Reynolds. Let me just introduce John. Dr. John Reynolds Wright works very closely with Professor Sharon, and he'll speak to some of the research that he can speak to some of the research that he's been doing with regard to the telemedicine service that is offered. And really what he's doing is evaluating women's and providers' experience with that particular model. And so between the two of you, you can agree between yourselves who responds yes. So the same question to you about what changes, what mechanisms and systems your facilities have put in place.
So I'll hand over to John in a bit for some more detail, but firstly, we work in an NHS abortion service which is based in the community, and it's based in a specialist contraceptive service, and we provide abortion care for women in the region, so about 2,400 women per year. So what we had to put in place, actually, very little, because we already had a self-referral system whereby women could phone up, refer themselves for abortion. So we didn't need to put that in place. We already had a website with information leaflets for women to read, and also an animation about what would happen at a clinic, what early medical abortion at home involved. We already, when we gave women their appointments, sent them a text message when that would take place, and that included a link to the website so they could get all the information in advance. So we already had all of that in place. So we were well set for telemedicine. We were also particularly well set because we just started a trial of telemedicine. So some of our staff had already got very familiar with not seeing so many patients in the clinic, because more and more women were being assessed by telephone. So that was really useful. But actually, I think for a service where the doctors and the nurses and the administrative staff are already used to seeing patients face to face, answering questions on the phone, it was really a very easy transition. And we didn't have to invest in any new technology, and most women are assessed by telephone, although we do have the option of sending women a link that they can get on their telephone if they want to have a video call with us, but actually few choose that. We already had protocols in place. We adapted those slightly. John can speak about that a little bit more in terms of triaging women that may or may not require an ultrasound. We already had a post-abortion support service that already was delivering that care to women either by telephone or over the internet, by video conferencing. What we did need to do, as Dr. Patricia Law and Michael have already alluded to, is we had to make up packs of all the medications and contraception and antibiotics and painkillers and pregnancy testing that women could either collect. But also we had an arrangement with some local hospital pharmacy vans that if women couldn't collect it, it could be delivered or even sent out to women living in more remote parts or more rural parts of our region. One thing that we did need to put in place, though, was we had to liaise, let our GPs in the region, the primary care teams know that we were moving from this face-to-face clinic-based consultation to telemedicine, and also make sure that staff in the hospitals were aware of that. But that was very straightforward, and that was by sending a large bulk email to all of those teams. Dr. John Reynolds Wright's been very closely involved in some of the redesign of the protocols and the training around that, and interviews of staff and women about their experiences. So perhaps, John, if I hand over to you now to say a little bit more in detail about that side of things.
Yeah, thanks, Sharon. So the evaluation of the service with the staff who've been working here has really shown in terms of what additional training they needed. Very few of them felt they needed to have any specific additional training, and that reflects what everyone else has said so far of many of our staff already worked on doing telephone triage or had some kind of telephone consultation component to their existing jobs, and so they were able to kind of build on those existing skills and apply them to the abortion service. Where there was kind of some elements of training, and this is specific to COVID, was because many other parts of our service were very abruptly closed down, we ended up with staff, an influx of staff into the abortion service who had either not worked in the abortion service for many years or had never done so before or had worked in it only infrequently. And so they needed a little bit of support and training in terms of the general process of providing early medical abortion care, but they didn't really require anything specific in terms of telemedicine. Likewise, in terms of developing the protocols around whether or not women needed to present for an ultrasound, this took a little bit of time and a little bit of engagement with the staff to give them the confidence to rely on women's last menstrual periods, and that was the main marker that we were using to assess gestation, and giving them the kind of support and training to ask the questions around how regular their cycles were, had they been using any hormonal contraception in recent last period normal for them, and then also trying to be practical about it and thinking, well, if there's a little bit of uncertainty between was your period 4 weeks ago, was it 8 weeks ago, but it's definitely one of those times, actually, regardless of that, it's going to be within the limit for having an early medical abortion at home, and it would be safe to go and provide them with that. And we also are lucky in our service that we have in-house ultrasonography, so we're able to bring people in for ultrasound scans if we do have any concerns over that. I'll hand back to you, Lucy.
Mm-hmm. Yes, thank you so much. That's so enlightening. Dr. Deborah, though you're not working, in a facility, so to speak, but I'd like you to just weigh in on the situation in South Africa and what, in the research that you're currently doing with Dr. Endler, have you come, is this something that has come up? What are the systems and mechanisms that facilities are putting into place to be able to offer these services, or have put in place to be able to offer these services?
Yes, thank you. So I'd just like to clarify at the start the situation with the public versus the private sector in South Africa. In the NGO private sector, telemedicine is, I would say, up and running, and there have been, as with BPAS and the way Sharon has described, few modifications required, and simply leveraging many of the existing platforms and practices, and it seems to have been a fairly smooth process. The public facilities, public sector is a very different kettle of fish. So different, it's chalk and cheese. And just to describe very briefly, we are running a trial in the Western Cape. We're at 5 public sector, 3 to 5, depending on what is open and what is not open at the time, public sector community health facilities. And these are facilities that provide a range of healthcare services at primary care level. And the trial aims to evaluate the safety, efficacy, and acceptability of early medical abortion provided by telemedicine in our setting in particular, because it has some specificities that differentiate from many other settings around the place. So what we're finding to date, we're about, well, we just got started and then there was the shutdown, which was a huge blow, but we have been able to continue, albeit at a slower pace. And what we're finding out is that women are interested. Women are very interested to join the study. They're interested in using their phones for assessment. They're in what we use is a modified version of the Women on Web platform that's specifically channeled through to the study. So there's a lot of keenness, and to date we've had quite a lot of success. But there are a lot of difficulties that we're also encountering, and some of them relate to simple connectivity and the fact that women often don't have data on their phones and don't have money for data on their phones. And secondly, the issue of gestational age is quite a thing. It seems to be more of a problem here. There's a lot of use of the injectable contraception, so many women have not had periods, although obviously they've stopped using the depot. So there's a lot of irregularity in menstrual patterns, and there's also a lot of fear that they won't get the service, I suspect, although we're not 100% sure that this is the reason. Women might choose to, or be inclined rather, to underestimate gestational age. So one of our field workers said the other day, whatever prompt and probe you use, you just can't be 100% sure that 100% of the time you're going to get this right, which I guess is the case normally, but I think it's a little more difficult. And this has been, shown in the published evidence over the last couple of years, studies comparing gestational age estimation in our setting compared to the US and compared to the UK and Europe and what have you. So that is that is a difficulty. But what we're doing in the study is we're asking clinicians to confirm gestational age using bimanual palpation. And this is really, for study processes and is not part of the telemedicine story. But for example, Marie Stopes are limiting telemedicine. Marie Stopes, South Africa, are limiting telemedicine to women who can confirm through LMP that the gestational age is not more than 56 days. So there's a little bit more of a safety margin that they're building in there. And there are other questions that I think can be asked that will get to a very much more accurate assessment than we are, than one started with just by asking somebody when was your LMP. Yeah, so I think for now, does that answer your questions?
Yes, that's quite interesting, and I'm sure my colleagues, on the continent that are listening have quite a number of questions, especially those that are beginning to either implement this type of model to ensure access to services or are thinking about implementing. So I'm just encouraging them to put in their questions, any comments that they have, so that in the chat box, so that as we are proceeding, we actually have the presenters looking through and responding or taking them on the floor. This brings us to the next question of, informed consent and privacy. So what process is followed to ensure informed consent and privacy for SRH services, including self-managed abortions? And you can speak about whether the process is different, where the patient is a minor, and the issue of when there's a requirement for written consent, how is that requirement met? We can begin again with Professor Patricia, Dr. Patricia, sorry, and Michael.
Thank you, Lucy. I'm actually going to let Michael pick this one up. I think I'll let him sort of take this one, and then I can pick up any follow-on questions. Is that okay?
Yeah, thank you. So please let me know if you can't hear me properly, but I have logged in and logged out again, but please let me know. So we did require a written consent from our clients for medical abortion and surgical abortion. And when we needed to provide this totally remote service, I did a lot of reading around recommendations for consent and the legality for consent. What I found in this country is that a written consent is required for somebody, it's recommended somebody undergoing a surgical procedure where they'll be receiving some kind of anaesthetic or sedation. And there wasn't actually any requirement for taking a written signed consent for somebody having a medical procedure. And when you think about it, that really makes sense. These women will be taking the pills themselves, and so once you take that into account, there's sort of this consent around that they've given because they're typically taking the pills themselves. What we did was we changed our consent form so the emphasis was put on the clinician making the declaration. So instead of having a section where the client would read and then sign to say that they agreed with everything, we totally turn it on its head so that the clinician had to sign. So the clinician now has to sign a number of statements on behalf of the client. I mean, it sort of says things like, I can confirm that the significant, unavoidable and frequently occurring risks have been explained and that the client understands and accepts them and wishes to proceed. And that the client understands any procedures in addition to those described on the form only carried out if necessary, etc. So the emphasis has really now been put on the clinician signing the form to confirm that exchange of information and to confirm that that exchange of information has been understood by the client. So that's with regards to adults, and we do that with all over on telephone. But when we are undertaking consent and assessing somebody's capacity to consent when they are under 18, particularly under 16, we do have some legislation in place called Gillick and Fraser. So we do have to do a competency check on young people. And we have been conducting the safeguarding risk assessment and the consent element of the consultation for abortion via video. And we've been doing that for a couple of reasons. One of the reasons is to ensure that the person is on their own. And what we do is we ask them to pan the video around the room. You know, we had quite a lot of discussion on what we would do with young people, and we really wanted to provide the service, a remote service for them. We really felt that perhaps some of our most vulnerable people having the most difficulty to access our services, we didn't want to disadvantage them by making them come for a face-to-face consultation or to collect their medication. So we started using this video, and as I said, one of the reasons is to ensure that they're on their own and not being coerced. And the other reason is to just get a visualization of them, just to see so that we can see their age, see what they look like, and to see how they're responding to the question. And so we do allow young people to provide consent remotely, where the nurses and midwives sign that form to say that that information has been exchanged. And I'll just go to Patricia, see if there's anything she would like to add.
I don't. I might just, the only thing that I might add is that we do provide people with the consent form electronically so that they can see it. And also we have available to them on the website, which is easily readable on a smartphone, for example, all of the risks and complications, so that at the time the nurse is going through the risks and complication of treatment and obtaining confirmation from the client that they've understood and they wish to proceed, that the client is able to look at that information and the content of the consent form at the time that that discussion is happening over the telephone.
Thank you very, very much. Professor Sharon and Dr. John.
Okay, so maybe if I start off and John, you add. So very similar to the situation at BPAS, we make sure when women are phoning to get their appointment that they're directed to the website for all the information in advance, and they get the link. We actually use exactly the same form that they would use if it was face-to-face. So the forms that women would normally fill out are simple tick boxes saying, I understand that there is a 1 in 100 risk of a continuing pregnancy after treatment. So on the phone, we will go over the procedure and then we will read through the form with the women and sign at the bottom that we've taken verbal consent, so that there's written, we're documenting that exactly what we've taken consent for. In the packs that the women have to take home, they also get written information again about how to administer the medication. John, maybe I'll let you speak about the women who are minors, and in Scotland a minor would be under 16. I guess the only other thing to add is that when we are on a telephone consult with a woman, we try and be aware of whether she may be being coerced into the situation, be alert to possible gender-based violence. And so when women are phone and get their appointment for the consult, they're all advised about an unsafe word or a safe word that they can use during the consult. For example, handbag, that would alert us that they may not be safe at home, and we would then arrange to see them at a face-to-face visit to assess them more fully. John, if I hand over to you to add.
Yes, thanks, Sharon. So in terms of managing young people or minors, so as Sharon said, in England and Wales, a minor is anybody under 18, and in Scotland it's somebody under 16. What we would do is, we don't have a fixed mandated rule, and we sort of deal with it on a case-by-case basis. So if there's a young person who is 15, say, and they've disclosed to their mum or somebody who is at home with them, who can support them, who's aware of what's happening, we're able to speak to both the young person and their mum or their carer, whoever it is, and we feel that they are safe and they've understood and they have got all of the support in place to have their treatment at home. We would treat them no different from anybody else. But contrast that with a situation where this was somebody who was hiding the pregnancy from a family, who would not be able to have their treatment at home, or would face kind of repercussions if that was the situation, or if they disclose over to their phone that there was some other worrying features going on in terms of coercion or abuse in their life. We would make an arrangement for them to come in and perhaps offer an ultrasound scan as part of that, but then that would give us the opportunity to see them in clinic and assess whether or not there are any safeguarding issues that needed to be addressed, and try and make a plan that would suit them best and keep them safe going forward.
Thank you very much. Dr. Deborah?
Right. So for telemedicine, for any procedure, a written consent from the patient is required as South African guidelines. And I understand the way that Marie Stopes is doing this is that they will email the form to the woman who's requesting a medical abortion, and they will run through it with them on the telephone and ask them to sign and then scan. But if that is not possible, what they do is they record, the whole consultation is recorded, and they also ask for a WhatsApp written consent agreement from the woman, and that is put together with the recording, and that is considered sufficient. In terms of, so that's the way they're dealing with that. And the teleconsult is done between the woman and the nurse provider. So there's not an additional clinician or additional healthcare professional required to be in this particular loop. For minors, no additional parental consent is required by law, according to the Choice on Termination Pregnancy Act. So that's not a further obstacle to a minor getting an abortion anyway. And I don't know that would that there's any additional procedure in place for that Marie Stopes is implementing at all. I don't expect there is.
Thank you so much for that. So the question of in all the presentations, there's been the issue of confirming the safety around the gestational period, etc. So how do you ensure that you obtain accurate information from patients that might be necessary to provide directions for self-medicated abortion and contraceptives? Again, we can begin with Dr. Patricia and Michael.
So can I just clarify, is the question about ensuring that we're getting accurate information, or is it how are we assessing somebody meets the gestational age criterion?
I think it would be both. Okay. How do you, yes, both.
Yeah. So I think, so I'll speak to the first one first, which is that we start from a position of believing that the information people are providing to us is as accurate as it can be. Deborah kind of touched on this a little bit in her introduction. You know, this is a difficult time. People are scared to leave their homes. I think the influence of the pandemic is real, and there may be some people who are really desperate to get an abortion and maybe don't feel like they have any other way to get it except through this kind of a remote service, and so may not be providing as accurate information as we might wish. But we, you know, and we can't prevent that entirely. I hope I'm making myself clear. So we start from a position of believing that patients are giving us as accurate information as they can do, and we help them to try to give us accurate information where there seems to be some uncertainty. And so this then gets to the criteria that we are using. Now, BPAS is a nationwide organization. We have hundreds of nurses undertaking consultations for us, and so we tend to standardize the way that we do things. as a way to ensure consistency of approach and so that we can do some evaluation. And so we do have a set criteria for who does and does not need an ultrasound to determine gestational age. And the very first of those is, of course, making sure someone's had a positive pregnancy test, and then asking them if they know their last menstrual period. We want to make sure that we are taking the date of their last normal menstrual period. So we also ask some questions of them about the quality and duration of the last bleed that they had, to help them and us feel confident that that really was the date of their last menstrual period and not bleeding due to some other cause. We recently introduced a criterion of having regular periods. So prior to this recent change, we were permitting people to access this service even if they had irregular periods, but if they were confident that the last menstrual period was a real menstrual period. We've since tightened up on that criteria, and we require that they have a history of regular menstrual cycles, so whatever that might be for them, but normally monthly, right? And then we assess some other medical history that might alert us to a concern about an ectopic pregnancy in particular. So whether they've had pain or bleeding of concern within a few days of contacting us, and then some specific historical characteristics that raise the risk of having an ectopic pregnancy. So for example, a prior ectopic pregnancy, a history of tubal damage or surgery like a tubal ligation, or having an intrauterine contraceptive in place at the time that they got pregnant or currently. And of course, we want to remove any IUD before we administer medications for a medical abortion. So those are the criteria that we use to decide who needs an ultrasound. So they need to have a certain LMP, regular LMP, have had a normal last menstrual period, and then not have any of these other features that would raise their risk or be suspicious for a possible ectopic pregnancy. So I'll pause there.
Thank you very much, Dr. Patricia. Michael? Yes, Michael.
So the only thing I'd like to add is around the conversations that we had with our staff around this approach, because my staff will always remember that one client who said that they believed that they were 6 weeks pregnant, and then on ultrasound were around 18, 19 or 20 weeks pregnant. So there was some nervousness around our staff, and so it was about ensuring that they had a really good understanding of why the service was coming in. And obviously with the COVID outbreak, it did make it much easier for us to implement this sort of service, because people wanted to work remotely and could understand the importance of it. But we've had to do some real good data collection on ectopic pregnancies and perhaps gestations that were over what we thought for early medical abortion, just to give some reassurance to our staff about that. But that was really one of the nervousnesses, and if you are going to implement this, they're the sort of discussions that you should be having with your staff. And there are some published studies out there that will give you some ideas of how accurate women can be around their LMP and what the error estimations may well be. And that was all I wanted to add. Thank you.
Thank you. Thank you very much. Professor Sharon and Dr. John.
John, I think I might let you answer this. I feel I've got very little to add over and above what Patricia and Michael have said already.
Yeah, I agree. the only things that we might incorporate slightly differently into our questioning around gestation would be how, in terms of establishing certainty, there's a lot of young women who will use apps or keep a really robust record of when they are having their menstrual periods. And so if they're able to kind of refer to that information, and it kind of strengthens our certainty of their dates. The other thing that we might incorporate is if somebody has got very irregular periods, but they are very certain that of the time that they were at risk of falling pregnant, or the time that they fell pregnant from a sex act. For instance, if they'd not had sex for a long period of time beforehand and then had fallen pregnant, or if they had had a previous negative pregnancy test at some point, we might incorporate that information into their gestational aging.
Thank you. Dr. Deborah?
Yes, so I do think that we could safely provide telemedicine for medical abortion in our country using LMP and using standard questions. I do think that we need to emphasize, in this country, we need to emphasize that as long as a woman's gestational age is within the legal limits for the country, she's likely to get the procedure that she needs. It just may not be telemedicine for her, and that she will be able to be referred. And given those kind of reassurances, I do think that we would have a go forwards for telemeds for medical abortion, and hopefully be able to have the gestational age up to the full first trimester. I do think this is something that's coming in the future. Yeah.
Thank you so much, Dr. Deborah. Yes, Dr. Patricia, you can. Yes, please proceed.
Thank you. I just wanted to add one comment here, which is, hello.
We can hear you. We can hear you.
Oh, sorry, I had a little moment on the computer there. Sorry about that. I just wanted to add one comment, which is that we talk to people about a couple of things when we're when we are consenting them for a remote medical abortion. One of them is that we say to them, you know, to reassure them, if you need an ultrasound, we will provide that in the safest possible way for you, because people are nervous about leaving their homes, and they are nervous about coming into healthcare centers. So we want people to feel comfortable coming into a clinical setting to have an ultrasound if one is needed. And we're hoping that by informing them of that, they will also provide us with accurate information about their last menstrual period. We also talk to them about the potential for there to be an error in gestational age estimation using LMP alone. And we're quite open with them about that. And we tell them that there are two possibilities, roughly, if this were to occur. One is that the medications might not work at all. The other is that the medications could work, but they could be delivered of a fetus that's farther advanced than they thought, and that the abortion experience might be associated with more pain and bleeding than we would have anticipated from an early medical abortion. So we have incorporated some specific counseling around the potential for error in our consent process. And that's been a learning experience. We weren't doing that at the beginning, but now I think it's an important part of what we do to help prepare people for the fact that there could be errors. And while we might want to really minimize those errors, we're probably not going to be able to eliminate them completely.
Thank you so much, Dr. Patricia. So this brings us to just some kind of contextual, conversation for those in restricted settings where abortion care is extremely difficult to access. There are several questions, and I suppose that's where that's why the framing of these questions is the way it is, because we are all trying to understand how we can facilitate, how we can navigate the legal framework as it currently is to enable women and girls to access services. And so the question of infiltration is very real in our context. How would the service provider be able to safeguard the system from infiltration by ill-intentioned patients, or just to avoid traps laid by the opposition to disrupt provision of abortion care? Dr. Patricia, back to you and Michael.
So so this is on the back of a report that came out in a UK newspaper called the Daily Mail on Sunday, where we actually learned that an anti-abortion organization had mystery shopped our service in order to try to write a report exposing the problems with the service from their point of view. So we now have had direct experience of this, and this isn't the first time that an anti-abortion organization has targeted us, and they also targeted Mary Stopes in the UK. And certainly, doing things remotely, potentially, I suppose, could increase that risk, but it's present whether remote or in person. I think the most important thing, and what I was heartened to learn about the interaction that these mystery shoppers had with our clinicians, is that your clinicians really follow the protocols, and if you follow the protocols that you've laid out for providing safe, lawful care, they don't really have a lot of place that they can go to. And this was the situation with these mystery shoppers. It remains the case that 2 doctors have to approve every abortion that's undertaken in this country, and we have a system for that. It remains the case that we have gestational age limits for who can access these medications at home, and we applied the criteria that we used to make sure that these patients were eligible for that service. So I think this is a real possibility, and we've seen it happen here now in the UK, sadly. And that the most important thing that you can do is to have your clear protocols and procedures laid out for how you are going to deliver this service within the constraints that you are working, and ensure that your staff adhere to those.
So I think you raised a couple of really important issues in your question, and one is one of those Patricia's addressed by information from opposition, but there is also, as you alluded to, some safeguarding issues here, where perhaps somebody's accessing and trying to get pills to provide for somebody else. And I think that what we do is we do the best that we can. We don't routinely ask CID, but we do routinely check patients' NHS numbers. We're able to access the national system for that, and that includes sometimes an address check, so we know where the pills are being sent to. But I think in terms of the service we provide, it is about doing the best that we can. There's a lot of questions that we ask around fact-finding, around the consultation, and if there is any doubt as to whether anybody's not telling the truth, then there is an opportunity for them to be brought into the unit, and are trained to sort of recognise when perhaps somebody's being coerced or some talking in the background. So perhaps if the story was right, they would recommend that they were brought into the unit for that. But at the end of the day, we really can, and as Patricia says, It's about us following those robust protocols we've got in place to ensure the safety of the people.
Thank you so much. Professor Sharon and Dr. John.
So yes, as has already been said, it's not, we can't prevent this, but it's important that staff know what the legislation is for the country, what the protocols are, and staff are often very attuned, and even without face-to-face consultations, as Michael has said, sometimes you might think, oh, this sounds a bit strange, or you might be a bit suspect by the individual on the phone or the background noise. But as long as you stick to protocols, and if this does happen, support the staff, because it can be a very distressing event for all staff involved if there is something like a tabloid newspaper that tries to make a story out of trying to pretend to be a woman seeking abortion care. John, have you got anything else to add?
I think it was just what Michael said about offering to bring these people in and bringing them into clinic, because I think that might unsettle somebody that is trying to kind of maliciously target the clinic. If you actually brought them in, and it would perhaps give you more of a chance to be aware of what was going on when you saw them. And if they were pretending to be pregnant and weren't pregnant in the first place, if you then offered them a scan, then that would kind of become obvious as well.
Thank you. Dr. Deborah?
I think that we've had less of a problem with so-called mystery shoppers than certainly has been the case in the UK. In terms of the regulations for telemedicine, all sort of electronic communications have to be filed and passworded and encrypted where that is feasible. Personally, I don't know how encryption works, but anyway, that is what is laid out in the guidelines. People on the webinar probably know that we do have a very big problem with so-called backstreet providers, which is not regulated, although so many other things are regulated. That is not addressed. And so I don't think I have anything, additional really to add, other than doing the best you can and following the protocols very, very correctly is the way to go. Yeah, thank you.
Thank you all very, very much for what I feel has been a very, very informative webinar. And just before we go into plenary, we have a few minutes left, but I want to bring in Dr. Chelsea Moroni. Dr. Chelsea, are you with us? Dr. Chelsea? Or Professor Jane Harris, if just to bring them in to share any insights they may have, anything they want to add before we, we invite folks to share any questions that they have. Professor Jane? Professor Jane, you're on mute. Professor Jane Harris, if you're trying to speak, you're on mute. Dr. Chelsea as well. Yes, yeah. Yes.
It's Jane. No, I've got nothing to add at the moment, thanks. Maybe when the questions come up, I might add there, but at the moment, I think it's all been very comprehensive and clear. Thanks.
Thank you so much, Professor. Dr. Chelsea, you're also on mute. Okay, she's probably experiencing some technical challenges. But so I want to open it up to plenary. If anybody that has a question, you can raise your hand, you can write your question in the chat box. If you have a comment, please feel free to jump in. Any questions, comments? Okay, I see a comment. Okay, and as we wait for people to share their questions, I'll probably invite Dr. Endler to share a bit, to speak a bit more about any comments that you have arising from the work that you're currently doing or your other engagements on this subject.
Hi, everyone. I am Debbie's co-principal investigator in this trial that we are performing in South Africa at the moment. I'm also a Swedish gynecologist and obstetrician. So I think you've covered a lot. Feel free to interrupt me if there should be any other questions. I'll just add a few thoughts. And it's been very interesting to listen to the UK and the Scotland perspective. And I think there's a lot of lessons to be learned and then some differences that we'll have to navigate through. I mean, one I think is that South Africa and Africa going forward will struggle to provide the kind of personalized medicine that you provide at the moment. What we are testing is a pure online service. And there we do see some difficulties with gestational age estimation, partly perhaps because it's a very special demographic. We found in our previous studies that these are women who to maybe 50% live in shack type of housing, are unemployed, often go without food. So it's a special demographic, and but perhaps those that most need telemedicine, which it's essential to find a service that works for them. My other thought was around, sorry. So the question of these mystery guests, which I think is important to sort of mitigate, particularly if you have a purely online service as we do. And I think there the risk increases a little bit. I mean, as you said, if by voice you can be alerted and you can check for things. I know there's an organization called Triggerize that work a lot in Kenya distributing HIV tests, pregnancy tests. And it was interesting to speak to them because they definitely have more superior technology than we do. And they initially saw a huge amount of fraudulent users, I think up to 40–50%, but we're able to bring that down to, I think, less than 1% through facial recognition and things like that. So I think there's an enormous, I think we can achieve a very workable solution for Africa in telemedicine, just with a few little modifications. Yeah, that was all.
Yeah. Thank you so much, Dr. Endler. Any question, comments?
I have a question. Sorry, I couldn't find the hand to put my hand up. So
that's okay. You proceed.
Jane. Yes,
yes.
Just following on from Margit, what we're talking about, and I think also in countries where there is a far more extensive online presence, I'm talking now pre-COVID, of access to medical abortion medication. I think in South Africa, we do also need to acknowledge that we might run the risk of also illegal, informal online medical abortion providers, illegal providers. And I think I've done some work around this in the past, and so that women are not confused, that they're able to identify what's a legal provider as against a provider that's not illegal, because some of the sites are quite clever in the way in which they present themselves. But once I suppose you try and access the medication, I'm not sure. Usually you have to go and meet somebody sort of clandestinely. So maybe that would make it clearer for some women. But we have found that a lot of women have, accessed unofficial medical abortion providers online, because it's very, very easy to advertise online. Thank you. It might be useful. I'm not, oh, okay, there's somebody maybe responding. Thank you.
Yes, I can see Dr. Patricia's hand was up.
So just very briefly, just to let people know that the remote model that we've implemented, that NHS has implemented, that MSI UK has implemented, has made it so much easier for women to access abortions. And, many of those women who otherwise would have in this country attempted to obtain medical abortion drugs through online providers, which is illegal here, or trying to access pills through organizations like Women on Web or Women Help Women. What we have learned from Women on Web and Women Help Women is that the need for women to access their services has absolutely plummeted since the implementation of lawful remote medical abortion services. So I think that just maybe as a point of advocacy, really, for people to think about in their countries, when, for, at least for the UK, what we're finding is that, with the ability to access pills like this from regulated providers, from lawful providers, and so on and so forth, women have not needed to go at least to the two most well-known providers of medical abortion pills in this country, which I think is it's a real success story, actually, for women who've needed to access abortion care.
Thank you, Dr. Patricia. So, John, do you want to add something?
Yeah,
Dr.
I was just
John?
going to add, in addition to what Patricia was saying, from the evaluation studies that we're doing with women in our service, women like having the treatment and they're accessing the service via telemedicine. It's very highly rated in terms of acceptability and how well prepared they feel for their treatment. And indeed, in terms of when we're asking women what they would like to see from developments of the service going forwards, continued access via the telephone at varied times with more of an online component to be able to kind of complete some of their medical history or what have you online in advance of their appointment. And indeed, postal and deliverable medications are all kind of features that have been highlighted.
Thank you, Dr. John. Yes, Professor Sharon?
I think that I think the other thing to add is that because access does not depend upon the number of women that can be accommodated in a clinic each day, we're finding that it's a more efficient way to deliver care, and with the same number of staff, we're able to have consultations with, an increasing number of women, and so overall that means that women are having fewer delays in accessing abortion, which is, a good thing. More of them will be at an earlier gestation, therefore, when we expect that they might be able to avail themselves of the early medical method at home if that's what they want. And we know that, the earlier that's conducted, more effective, less pain and less bleeding. So that's a good thing too.
Thank you so much, Professor Sharon. So I'm seeing who are the participant appearing as Huawei P30. You had your hand up. Huawei P30 Lite, your video is on. You can, yeah.
Okay. Thank you very much. Thanks, and thanks for all the inputs. The one thing that we may want to look at, I'm Eddie Msanga from South Africa, I'm sorry. And thanks very much for all the inputs. The one issue indeed has already been raised about the infrastructure that we in South Africa would not have. But some of us are looking and actually implementing what we would call partial telemedicine, in that the women would come in and then would be seen, but then we would then give them the medications for them to go and do it at home at their own convenience. And then a week later, then to come, if there are any problems, to come back for a checkup. So we limit the number of people who are coming into the facility. The issue of the wrong dates indeed is a challenge, particularly where there's so much violence, in that people firstly deny that they may be pregnant, but also the stigma around having been sexually abused, therefore delays them presenting early to the facilities. So I think that unfortunately, we although we use the last menstrual period for gestational age estimation, where there is doubt, indeed we would ask them to, to have ultrasound. But other than that, ultrasound is not the issue with us. And then the other thing, of course, is that of the teenage pregnancies, school kids and so on, who would hide the pregnancy and therefore deliberately say, no, I'm only 2 or 3 months, pregnant. But actually find that the height of fundus is well above 20 weeks. But those are some of the challenges that we have. But I think that we can look and say, how can we, even if it's partial, we then would be able to make the service more accessible. And we have seen actually more than 60% of the people coming in before 8 weeks of pregnancy, and therefore utilizing the medication abortion. But thanks very much.
Yes, so Michael, you want to say something?
Yeah, I think that really that just highlights that services really do need to be flexible. I don't envisage that we will ever go totally over to a remote service for women who would want to come in, or would feel that it would be safer for them to actually come in and have their consultation face to face in a safe space. So I just think that a lot of what you've said really just highlights that the services need to provide this remote service for people who need it and can be provided it safely, but also be flexible for women who want to come in and have easy
access. Thank you. Yes, Dr. Patricia.
And just to sort of piggyback on that as well, as I mentioned in my opening, that not everybody chooses or can safely receive their medical abortion pills in the mail. Some people don't have a home to which the medications can be mailed. For some people, it would not be safe for them to receive a packet at home. And so we do have the ability for people to come into the clinic and do exactly what was described, which is to simply attend to pick up a pack of pills that they can then take away and use, in a place that's safe for them, and at a time that's safe for them, within the gestational age limit for abortion, at least in this country. I think what I heard is that some people are limiting telemedical abortion services, or not using an ultrasound as routine to 56 days. And I think, that's perfectly fine, and you will run into fewer errors in gestation if you have a slightly tighter gestational age limit, but I think any moves that we can make to increase access to abortion through this method is a positive. And it doesn't have to be, up to 10 weeks or 12 weeks at the get-go. You can start more conservatively, and that will also perhaps give your staff more confidence in the model, and your patients, because word of mouth, of course, is important in helping people feel confident in whatever the health services that's providing care to the community.
Thank you so much, Dr. Patricia. So I note that we've run out of time, but I want to invite Dr. Deborah to probably make what will be the last comment or intervention, and then we close the webinar shortly.
Thank
Dr.
you. Yes. So we never spoke about the actual delivery of the pills themselves in the South African setting, and as Patricia noted, sometimes it's really not feasible to post them, and certainly in South Africa, posting or couriering is not always going to work. So pickup at a pickup point is probably the way to go. But just in conclusion, I'd like to say that given the input from National Department of Health, we're trying to look at something very broad-based. I think the way to go might be step by step, building on the guidelines that have been provided by others from different settings and scaling up very gradually, building on evidence is going to allow us a way forward, and in a very good way, certainly. Thank you.
Yes, thank you very, very much. I think I speak for for all the participants that this has been a most enlightening session. As I indicated, many of us are, grappling with telemedicine and how it can be delivered effectively, particularly in restrictive contexts. So these are the what you've shared is very useful learning for all of us. I want to thank all the facilitators. I really want to thank you for taking time out of your schedules to just enlighten us some more on telemedicine and how it's working in your contexts. Useful lessons that we will draw on, as we continue to interrogate this for our different contexts. Thank you all the participants that have stayed on up to this point. There was a question about the availability of this recording, so we will keep you posted on that. But secondly, if you have any questions, because you are unable to go through the session, we were unable to go through it. It was a very brief session. If you have any questions, you can forward them to us, and we will send them to the to the facilitators. Alternatively, you can reach out to, I can see Dr. Patricia has shared her some information here. Any questions that you have, kindly just reach out to us, share them with us, and we will be happy to facilitate some responses to them. So I want to close at this point. Thank you so much, and have a lovely evening, have a lovely day. Thank you.
Thank you, Lucy, for your very good sharing. Have a good afternoon. Bye-bye.
Bye. Bye.
Thank you. Bye-bye.
Bye-bye.
Bye.